Hello, everybody. Thank you so much for joining us today. My name is Salih. I'm a reproductive endocrine and infertility specialist here at UChicago, mainly working at Hinsdale and South Loop clinics, but we do go to Hyde Park as well. My talk today is going to be on fertility preservation concept and challenges, and I will be focusing on female fertility preservation, although we see both males and females. My disclosure, I do not have any conflict of interest. However, this is a topic that's dear and near to my heart. I see a lot of patients for fertility preservation, and I also involved in a lot of clinical and laboratory research in the topic. So the objective for this talk, we are first going to define who actually need fertility preservation. And then we'll talk about what are the options available for fertility preservation for women and girls. What are the challenges for fertility preservation? And then lastly, if we have time, I will conclude with where the research are going and what are some of the advances in the field. So who needs fertility preservation? Most of the patients I see in my clinic see me because they seek an elective fertility preservation. That's for social reasons. But I also see patients with medical condition, both those who have cancer and some patients who don't have cancer, but they have some other condition that affect their future fertility. We see women with genetic disorders that can affect fertility as well. We see military personnel as well as individuals going for gender affirming hormone therapy and surgery as well. So what is elective fertility preservation? Is mainly for women in their 30s who don't think that a good time for them to conceive at this time, and they want to preserve fertility electively to mitigate the age-related effect on fertility. As we know that as women get older, the number of eggs and the quality of eggs diminishes. So these women want to be proactive. And I really love it because I'm going to have to share with you, not long ago, I used to see a lot of women in their 40s very frustrated, not knowing why they're not getting pregnant. And they look so young, and they are young. But right now, I see women in their 30s trying to proactively preserve fertility, which is amazing. There are multiple reasons for that. Some of them don't have the right person. Some of them have some other commitment in their life, whether it's work or education related. Some of them are looking for better finances before they actually build a family. But there are some people who don't even, and they're not even sure they want to have a family in the future, but they just don't want to close that door on them. So they wanted to preserve fertility. And you know this, but I'll share this with you. So this is a couple of graphs explaining the effect of age on fertility and also the effect of age on embryo quality. So the graph on the left depicts on the x-axis, you can see the age of the women as women get older. And on the y vertical axis, you can see the pregnancy rates from IVF. And the orange line is women trying to get pregnant using their own eggs. And you can see very clearly as women get past 35, there is gradual decrease in fertility as women get older. Now, the blue line represents women who are trying to get pregnant. They're still older than 45 sometimes, but they're using an egg donor. And you can see the blue line remains the same. So this is clearly tell us that as women get older, there is something that happened to the quality of the egg that decrease the pregnancy rate for these women. So there is increase in fertility with advancing age. On the right side, you can see those histobars. Again, the same story. The horizontal line is the age of the patient. As patient get older, then the vertical line is the percent of embryos that's abnormal. And you can see very clearly as patient get older, the percent of abnormal or aneuploid embryos increase as well. And that's very important because what happens if women have aneuploid embryos? Those embryos do not result in pregnancy, so they have increased risk of infertility. But they also, if they can become pregnant, they have increased risk of miscarriage. And again, they have increased risk of pregnancy complication. So you can see very clearly from these pictures and graphs that as women get older, there is decreased number of eggs, and there is also decreased quality of eggs, leading to complications with pregnancy. So I love it when women in their 30s come proactively wanting to preserve fertility. But then another group of patients I see in my clinic are women, like men, women, and children diagnosed with cancer. And unfortunately, cancer is very common. Cancer is more common than we like. It turns out to be about 1 in 300 children will be diagnosed with cancer before they turn 20. And we have a lot of treatment nowadays. So it's really amazing that about 90% of those kids actually are cured from their cancer. But the problem is they are left with a lot of morbidity, either from the cancer itself or from the treatment of the cancer. And the motto goes, once a cancer survivor, always a cancer survivor, just because there's always something in your house that's not quite, that remind you that one day you had this thing. It's nothing like you can just throw behind your back and move on, unfortunately. And for us, the reproductive endocrine folks, we really care about reproductive health. And it turns out that about 7% of girls who are exposed to chemotherapy actually have ovarian insufficiency and ovarian failure. So it's quite a lot of children and young women as well. So here is the other indication for fertility preservation. So we see individuals with genetic disorders. So example of this will be Turner syndrome, who will have increased risk of ovarian failure. We know they have ovarian failure and ovarian insufficiency, but I mean, interestingly enough, those individuals with Turner syndrome are actually born with normal ovaries, with normal ovarian reserve. It's just that they lose their eggs very quickly during the childhood, so they have ovarian failure. So these young kids, we can also preserve their ovaries. Another example of genetic disorders are women with BRCA1. They have increased risk of ovarian tumor. They have to have their ovaries removed. And again, we can also preserve fertility for those women, preserve eggs or embryos, not only preserve them, but we can also screen the embryos for BCRA1, so we can decrease the risk of transmission of genetic or cancer gene predisposition in these families as well. Another group of patients I see is women with severe endometriosis and ovarian cyst who may undergo ovarian surgery. Women with endometriosis have endometrioma, they undergo recurrent or repeated ovarian surgeries, eventually leading to decreased ovarian reserve. So it's very important that we be very cognizant with those patients as well. Military personnel, not only they are exposed to toxin in the field, but they also may be away from their significant other for many, many years. And we know that age is very detrimental as well. So they have a double whammy there, not available and also exposed to toxins. And of course, gender affirming individuals, whether they taking hormone treatment, we know that hormone treatment can affect reproduction and ovarian function as well. And also if they're seeking surgery and removal of their ovaries as well for surgery affirming, for gender affirming surgery as well, those individuals also merit fertility preservation. And just for my audience, because I know you all do OBGYN, I just want to draw your attention to women with gynecological malignancies. And it's so interesting because a lot of people say, well, you have cancer in the ovary. We can't do anything for you. I mean, the ovary is gone. The truth of the matter, a lot of younger women do have what we call borderline malignant tumors, and those are prime candidates for fertility preservation. We used to take both ovaries out, but now, depending on the stage, we can actually take the ovary with the tumor out. I've seen a lot of those women as well. If they take the ovary with the tumor out, we preserve fertility from the other ovary, and then eventually they take the other ovary out. I think we can do a lot for those patients. But also, women with endometrial cancer, we don't need to take that uterus out. Sometimes we can preserve it and give them hormone treatment to preserve the uterus and have them get pregnant and then take the uterus after that. So there is a lot of ways and a lot of individuals that actually need and deserve to think about fertility preservation. So the next part of this, how can we preserve fertility? The truth of the matter is a lot of organizations, including gynecologic organization, reproductive organization, OBGYN, they always say any individual with medical condition who's going to be exposed to infertility merit discussion of fertility preservation. So it's very important we discuss this with all patients. I think how we do it, first thing we have to remember to discuss it with our patient. And then second thing, we have to have some knowledge about how we do this, right? And the bottom line is most of these are advanced reproductive technology, and most of it are revolve around freezing tissue. We can freeze embryos, we can freeze eggs, we can freeze ovarian tissue, we can freeze sperm, testicular tissue, and this is how this field is run. So here is a graph of what we can do for fertility preservation. So if somebody comes to see you, based on the age and the desire of the patient and a lot of other factors, the standard of care is to preserve eggs and preserve embryos. There's pros and cons for each. But you know that the eggs is the woman property, right? So it's her own. There is no custody involved. There is no issues. The eggs do very well. So I really like to preserve eggs for women, especially if they don't have significant others. But then women in a stable relation can be candidate for embryo cryopreservation as well. Younger girls, we cannot really preserve eggs on them. we will do ovarian tissue freezing, and I'll talk to you about it. But there's some other treatment for fertility preservation, hormonal surgery as well. So before we go further, I just want to share with you a few notes about the ovary. I think it's going to help you understand what I'm talking about if you know a little about the ovary, and I know you all do. But what does the ovary do? The ovary, if you look at it, is a small little structure, had a small little, the building units of the ovary is called the follicle. This follicle is a small little sac and it has the egg in the center of it. So it's a small little organ with a lot of follicles. You can see all kind of follicles, and these follicles get different names based on how developed they are, right? So the function of the ovary is one of two. Those follicles have eggs, and the eggs, of course, help with fertility. So if somebody have ovarian insufficiency, they will have infertility. But the other function of the ovary is to make hormone because those eggs have nursing cell, and the nursing cell around the egg are the cells that make the estrogen and progesterone. So these hormones are also very important for development, right? So what happens if somebody have say chemotherapy or have endometriosis and get their ovaries out or ovarian torsion and they have premature ovarian insufficiency? They lose fertility, so they have infertility. They can get pregnant using their own biological eggs, of course. But then they also lose the hormone. Loss of the hormone, the effect will depend on how old the patient is. Like children, if they lose hormone, then they don't go through puberty, right? So they're losing quite a lot. Where adult, if they lose hormone, they have problem with osteoporosis, cardiovascular disease, and bone loss, and a lot of other, because I know we all know that estrogen is very important for health in general. So the ovary is very important for fertility and also for hormone. If you look at the ovarian follicles, in general, the ovary have a lot of primordial follicle, which is the ovarian reserve. So the primordial follicle are very small, tiny ones that make the primordial reserve. And women are born with all the number of ovarian primordial follicle that they can ever have. A young baby girl will have about 2 million of those. As they grow, certain number will mature every month, and we lose them continuously, right? So when you look at the ovary, you'll find this primordial follicle, but then you find all kind of growing follicle. And these growing follicle are very, very sensitive to chemotherapy and toxins, right? We cannot really assess how many primordial follicle a woman have. The only way you can do that is to take the ovary and send it to pathology lab and have them count. But by the time you do that, you lost the ovary, right? So that's not good, right? So we can't, but we can assess how many growing follicles are there. And by doing that, we can get an idea about how many primordial follicles are there because they kind of correlate, right? So how do we assess ovarian reserve? When I see any women for fertility preservation, for fertility, for anything else in my clinic, I always want to assess ovarian reserve. I just told you I cannot count the primordial follicle, but I can count the antral follicle or the growing follicle. Those growing follicles, they look like a small little black circles in the ovary, so you can actually count them. And when we do the pelvic ultrasound, depending on how many follicles we see, we will know if this patient have a normal ovarian reserve. Usually they have about 10 to 20 follicles, small little black circles. We know if they have polycystic ovaries, high ovarian reserve if they have more than 20 small little black circles. And we know if they have diminished ovarian reserve, if we don't see any of those black circles, or we see less than 4, then this is very low ovarian reserve. So this is one thing that we can do, which is ultrasound. But we also do a blood test called AMH. You remember I told you those follicles have nursing cell, and those nursing cells produce AMH. So if you have a lot of follicle and a lot of nursing cell, you have a lot of AMH in your body. So these are the two things I always want to do for my patients before I talk to them about anything. I want to see what's their ovarian reserve and if they have good ovarian reserve or not. And amazing, you cannot look at any person and say you have a good ovarian reserve or bad ovarian reserve. You just don't know. The only way you do that is to do your pelvic ultrasound and do your blood test and try to talk to your patient. So now coming back to fertility preservation, how do we do it? I told you egg is very important for the quantity and the quality of the egg. But then egg is also very important because it tells us what to do with the patient, right? So we have kind of three categories in general. We have those adult mature women who come to see us. And this is really the easiest group that we deal with. It's very easy to, if they have eggs, we can preserve them, right? We see another category, which is number 3. These are the prepubescent girls who are younger, have not gone through puberty. This is kind of a challenging situation because although they have follicles, but they don't really mature. So we cannot really freeze eggs for them. and they are very small girls as well. So you can't really do transvaginal ultrasound and all that, right? So those ones we tend to preserve ovarian tissue, and we only do it for girls who are being diagnosed with cancer or something serious that gonna really kind of Turner syndrome or something that gonna threaten their future fertility. So we have the mature adult and we have the prepubescent girls. In between, we have a group of which are adolescent and young adult. And this is kind of can go both ways. These are young adolescent girls who are reproductively mature. They have periods, they can make follicles, they can grow them. But mentally and physically, they may be still young, just going through puberty. So they may not be ready for fertility preservation the way we know it, right? So for this group, it really depends on where they want to go. If they want to have eggs, we can do that. If they feel this is not for them, we can also freeze ovarian tissue. So this is a very important concept about you look at the age of the patient and you try to decide what is the best fertility preservation option for that person. So let's start with mature reproductive age women who come to see me for social, like somebody in their 30s, they just doing their, nurse practitioner, they're really busy or doing their nursing degree, they don't have time, they want to preserve fertility. The best thing to do for those is to freeze eggs or embryos. And the success rate for freezing eggs or embryos is very good. It really depends on the age of the patient, but if patients are younger than 35, success rate is really very good. And whether you freeze eggs and make embryos from frozen eggs or make fresh embryos, we have about 40 to 50% success rate from those embryos. So, and the more you freeze, every embryo will give you about 40, 50% success rate. So if you have more embryos, then that's good for you. So when I talk to patients, I always want to have a contract up front. It's like, how many eggs do you want to freeze and how many embryos do you want to freeze? Now, of course, this process takes time and sometimes it's expensive, sometimes it's not covered by insurance. So there's a lot of things, a lot of discussion that goes into it, right? In addition to freezing embryos, women can also freeze eggs. Freezing eggs is really nice because it's your property. You can do whatever you want to do with it. Like, nobody can get into it. It's not like the embryo. There is a lot of hype around embryos depending on where you live and the state and the government and whatever. But eggs, there is no discussion. It's your eggs. You can do whatever you want to do with it. The problem with the eggs are very big cell and they're very fragile. So they kind of need this special tender care to freeze them. The egg is a very big cell that's full of water. And as you know, if you have a soda can in the refrigerator and you want to freeze it, it can pop, right? So the same thing with the egg. So we have to use very special ways to freeze them. And not only that, they're big and full of fluid, but they're also in a very delicate developmental stage. They have very delicate spindle fibers and they have those chromosomes in the center that can be easily damaged. So again, you have to have a good clinic with good success rate and good embryology to trust them with your egg. Not like the embryos. Embryos, everybody can do them. But those eggs, you really have to be careful where you want your eggs frozen. And there is a way that we can freeze them called vitrification, which is a new way to freeze, as opposed to the old way of the slow freeze. And that vitrification works extremely well with the eggs. So again, advantage of the egg, they have minimum legal and ethical consequences, right? And, so I think I like to do that a lot. But again, if somebody have a stable relation and have a partner, we can do embryos. The advantage of the embryos are many as well. And one of them is you can do genetic testing for the embryos as well. You cannot do that for the egg, but you can do it for the embryos because they have a lot more cells, right? This is just a slide about vitrification, which is a special way that we freeze eggs. And we now actually use it for embryos as well. And it has really improved the success rate. When I started doing fertility many, many years ago, we used to always thaw embryos and see like, oh, how much of the embryos survive the thaw? Is it 50%? Is it 90%? With vitrification, it's always 100%. Some of them don't make the thaw, some of them don't. But if they make it, they always make it like proper, like we don't have that issue anymore. So vitrification is another way to freeze properly. And, these studies were done now 2013. This study has shown that making embryos from frozen eggs and fresh eggs have the same success rate. Because obviously we didn't know that, right? So we had proven it again and again that frozen eggs are just as good as fresh eggs, and this is the standard of care right now. But you have to remember, not every egg make an embryo, right? Like women will have 2 million eggs, I told you, when they're born, but they only make like 4 or 5 embryo, like babies, right? But the most maybe 9. So basically, then the chance of every single egg making an embryo is about 4 to 12%, depending on the age. So it's very important to talk to your fertility doc and sit down and say, hey, what's my chances and how many eggs I want to preserve based on my age and my ovarian reserve as well. So then the next part of this talk, I want to tell you how we preserve eggs. What happens, right? I think it's very unique because it's advanced technology, it's very advanced, right? And here are the steps that involve in egg freezing. If you want to preserve your eggs, it takes about a couple of weeks to prepare your egg. It's only 2 weeks, really. It doesn't take more than 2 weeks. There's things that we do before, and there is recovery after. But the process itself, it tops 2 weeks, right? And there is certain things that we do. We do an ultrasound at baseline to look at the ovarian follicle, make sure they're normal. We do blood tests. And then we do an ultrasound every 2 to 3 days. You'll get injectable medication to make the egg grow. And then eventually, when those eggs are ready, we do a trigger injection to make sure they mature, and then we retrieve them. Here is the retrieval procedure. It's done under sedation, so you're not going to feel anything. And here is the ovary with those black little circles that's grown after 2 weeks of injection. Uh, And this is how we do it. So it's going to be a transvaginal ultrasound with the needle going through the vaginal skin. That needle goes into the ovary, and then we kind of suck the fluid. This black is really colorless fluid. We give it to the embryology lab. The embryologist is going to look under the microscope. They're going to find the eggs. And this is what the egg look like. And they're going to freeze the eggs. If that's what you're doing, we freeze the eggs. If you're going to do fertilization and make an embryo, then we're going to inject the embryo in. We inject the sperm in, or we mix the sperm with the egg to make embryos, right? So it depends on what you want, right? Here is the egg that's been fertilized in normal fertilization. This is what they look like. They have pronucleus, female chromosomes, and male chromosomes. And here is the embryo that's growing in the lab, and it looks beautiful. So we don't really see it. We don't really check on the embryos every day. We just leave them in the incubator to kind of chill because it's not good to get them in and out. But this is what they look like. On day 1, they divide into 2 cells. On day 2, they divide into 4 cells. On day 3, they divide into 8 cells. And they keep dividing. On day 4, they make something very unique called a morula. You don't see the cell, you just see a mass of tissue. And then on day 5, they differentiate. This morula, then they differentiate. So you see a small little group of cells, they call them the inner cell mass, that makes the embryo. And then this cell on the outside, the outer cell mass that makes the placenta. So now we have a differentiated structure, right? And then eventually, when the embryo reaches the blastocyst, it hatches because it's wanting to implant. So it has to come out of this capsule, the zona pellucida, so it can hatch. Something very interesting that we can do is to do a biopsy for the embryos. And this is really important. I see a lot of people for IVF, not because of infertility, not because of fertility preservation. I see them because they have genetic disease that they do not wish for that genetic disease to be transmitted to their offspring, right? So we can actually do biopsies. A, make sure the number of chromosomes are normal, so there is no aneuploidy. And B, we can check for single gene disorder like cystic fibrosis, sickle cell anemia, thalassemia, BRCA1, whatever. All these cancer predisposition genes, we see a lot of those women as well. Okay, got it. So you're going to ask me now. I talked to you about fertility preservation is very important. I talked to you about how we do the IVF. I told you that we give a lot of injection. So what happens when we give people injection? Their estrogen becomes really high, right? And that's a problem for some people who have hormone-sensitive cancer, right? This is one problem. The other problem we see in cancer patients is that in normal people, we have time. So if you want to do the IVF cycle, we're not going to do it tomorrow. We're going to say, hey, let's do it in 2, 3 months. We do the labs. We give you medicine to make sure that your eggs are synchronized, some hormone, birth control, maybe 3 weeks. We kind of make, it stacks the odds deck for you so that the cycle is more successful. But for cancer patients, we can't do that. They come today and we have to do things tomorrow, right? So there's a lot of modification that we do for cancer patients. And I'm glad to say these modification work, and we're actually very, very successful. So, usually it takes about 6 to 8 weeks for a regular person to do this, but for cancer patients, 2 weeks is what it takes, right? So 2 weeks, what it takes. So basically then, sorry. So because we do what we call random start. They come to see us and we start them tomorrow. We start them in 2 days, right? We don't really need to synchronize like we do for non-cancer patients. We have protocols that's meant to have people recover very quickly. So I'm not going to detail you all these protocols, but we have a lot of things, little things that we do so that the cycle is really short and then the recovery is even shorter. So within 3, 4 days, those people get their period and they can go and get their chemotherapy. And then we also give them adjuvant medication like letrozole or tamoxifen that will decrease the amount of hormones. This is one of the studies that was done to compare breast cancer patients who have IVF and control patients. And the breast cancer patient got letrozole and the control did not. So here you can look at the level of estrogen, and breast cancer patient, their estrogen was only less than 500. Was the control, their estrogen level was 1500, right? But the number of oocytes, which was 12 and 11, was the same, and the fertilization rate was the same, and the pregnancy rate was the same. So giving letrozole to cancer patients is really good. Not only cancer patients, I see a lot of people with history of thrombophilia, factor V mutation, people on anticoagulation, history of clotting. There is a lot history of migraine headache. There is a lot of people history of rheumatoid arthritis. There is a lot of people that estrogen is not good for. It makes them sick, right? So with those patients, we have a lot of protocol that we can do for them as well, right? And this is a very interesting study which came a couple of years ago. This is really a key study in our field. We always were worried in our heart that maybe those cancer patients, by giving them medicine for 2 weeks and increasing their estrogen, maybe we are making the cancer worse. Maybe we are increasing the recurrence rate and mortality. We didn't think so, but we were not quite sure. But this study was done a couple of years ago. And basically what they did, they took about 500 breast cancer patients who already they were all estrogen receptor positive and progesterone receptor positive. And they all received treatment for about 1.5 to 3 years. So they received treatment like letrozole and tamoxifen for about 30 months, endocrine treatment. And then they stopped the treatment and for 2 years, and they got pregnant and they resumed the treatment again. And by doing this temporal planned interruption of hormone therapy, that was very safe. It did not increase the recurrence rate. So you can see here in the cancer population, the recurrence rate was almost 8.9%. And in the control population, the recurrence rate, historical control, was 9.2%. So this study for the first time shows us very clearly that it's okay after 1.5 to 3 years of hormone therapy after cancer, it's okay to stop and get pregnant and then go back onto the hormone therapy. So that's really important. Right. So now we had discussed a lot of things, right? We discussed the indication for fertility preservation. We discussed how we do IVF. We discussed the modification that we do for cancer patients. And we also discussed this is kind of, proving that it's safe for cancer patients that we can do, right? So it's not all about IVF. There are some other things that we can do for cancer patients. And I want to discuss those with you as well. I'm sure you heard about it. Some patients who have like breast cancer and so forth, they will take Lupron, which is a GnRH agonist. Lupron is the same medicine that you'll give for endometriosis to suppress the ovary. So it's a GnRH agonist that will suppress the ovary. And the whole point, you remember I showed you the ovary, there is two kind of follicle. There is the ovarian reserve, the primordial follicle, but then there is a growing follicle. And we showed that the growing follicle are more sensitive to chemotherapy. So the whole point of this GnRH agonist therapy that you give cancer patient in combination with the chemotherapy is to suppress the ovary. And when you suppress the ovary, then there is no growing follicles, then there is less damage to the ovarian follicle, right? The truth of the matter, the studies are very mixed, and some of them showed improvement, some did not, and even those studies that showed improvement is not really 100%. So I would say if somebody consulted me about it, I would definitely say it's okay to take Lupron and suppress the ovary during the chemotherapy, but I say that should not be the only modality that the patient does. In addition to doing that, I think we should promote proper fertility preservation, like freezing eggs, freezing embryos, and so forth, right? So this is a study that was done for breast cancer patients. They got goserelin, which is GnRH agonist. And you can see that patient who received this goserelin, ovarian failure was about 8% of the patient compared to the control were 22%, and the pregnancy rate was higher, twice higher in patients who received the goserelin. But again, it's not 100%, right? So 8%, 8% of people still have ovarian failure, and a lot of people that get pregnant. So it's important to, do everything you can do. In addition to GnRH agonists, you also want to do proper fertility preservation, right? So what are the other options? I'm not going to dwell into this, but obviously the goal is to invent new medication and personalized medicine and precision medicine so we can actually take individual patient and give them something that's not going to have off-target effect and not going to hurt their ovaries or testicles or their heart or their brain. I mean, that's really the ultimate goal, is to have safe cancer medications, number one. And the goal for social freezing is to have ways to preserve ovaries and not have them go through menopause and ovarian insufficiency. And there are some studies going in the field by injecting, exosome and injecting stem cell and this and that. But all these things are really experimental and not standard of care. So fertility preservation is here to stay, at least for the coming few years. This is another thing that our GYN oncology people do when they have ovarian cancer patients who are going to get pelvic radiation, for example. They actually take that ovary out of the pelvis and put it all the way. You see, this is the liver. So they kind of detach the ovary and stitch it close to the liver so that the chemotherapy, the pelvic chemotherapy is not affecting the ovary. And this is really helpful if it's done properly. The problem is the surgery is difficult, and if it's not done properly and the ovary is not far away, the ovary can still be affected with the radiation. So that's one of the things. All right. So now everything I said is for reproductively mature women, women who gone through through puberty and they have regular period, and they can tolerate ultrasound and so forth, right? What about children? I mean, children is a whole new thing because we know that their ovaries have follicle, and those follicles grow. If you look at a young woman, a girl ovary, it have a lot of black circles, it have a lot of follicles. But those follicles cannot be, we're not able to mature them properly. And so far, only mature eggs actually make embryos. Immature eggs don't. So there's no point freezing eggs into these kids, right? So the other way what we do is we freeze ovarian tissue. And this is really also very interesting and very successful. So for these young kids or girls who are going to get like chemotherapy or bone marrow transplantation or something that definitely going to kill the ovaries, we will take one ovary out, and we have done few of those cases at UChicago as well. So we'll take one. We never take two ovaries. We always leave one in, just in case it makes it, right? But we take one ovary out, and then we kind of process that ovary in the lab, and takes the cortex, which is the outer. So if you look at so where are the follicles? The follicle and the egg are not inside the ovary; they're on the outside. If you have a grape, the skin of the grape, this is where all these eggs are. So basically, then we bisect the ovary, we take the inner part out, we leave the outer part, which is the cortex, cut in small little pieces, and these are the ovarian cortex pieces that we're going to cryopreserve. So this is what ovarian tissue preservation is. Like I said, we've done few of those, right? Um, Now, what do you do with ovarian tissue? You can freeze it as long as it takes, and then eventually you have to transplant it back to the patient. So it takes surgery to get it out, and it takes surgery to put it back. And I think that's one of the problems with ovarian tissue. It's not like the IVF. I mean, they're all kind of procedures as well. So basically, where do you put it back? We like to do what we call orthotopic, meaning putting it back where the ovary belong. Like if you have a stump of the ovary, then you put it back there. And that's really important because that can allow spontaneous pregnancy. However, there have been some case reports where they did heterotropic transplantation. So they put it somewhere else, not in the pelvis. They have put it in the forearm. They have put that ovarian tissue in the subcutaneous of the abdomen. And it does vascularize, it does grow, it does make follicle. But obviously, if you do that, then it has to be an IVF. So the best thing is to put them exactly where the ovaries are. So this is what we like to do. Unfortunately, there is not a lot of women who have ovarian transplantation back. There are a lot of people who got ovarian tissue removed and stored, but it takes those women so many years to come back. So there is not a lot to report on the outcome of those. But the few studies that came out are kind of promising, right? So here is, how you put it back. And so this is the ovarian tissue piece that we took out. You have to stitch them together to make a bigger piece. And then you open the abdomen and you kind of, you take that ovarian stump, you kind of refresh the surface a little, so it will have some blood vessels, and you put this piece on it and you stitch it. It's not really difficult to do, but you lose a lot of ovarian follicle when you do that because it takes a few days for it to vascularize. And by the time of vascularize, you lose some follicles. Here is a study that was done, not for cancer patients, but these are monozygotic twin women who one of them had ovarian failure, the other one did not. And they took one ovary, they did the same thing. I then transplanted it to the other twin. And they did this for 9 patients. And you can see very clearly, it took about, this is the FSH, which was very high before the transplantation. It took up to 3 months before the FSH became normal. So it took up to 3 months for those ovarian tissue to take and vascularize and become functioning and make eggs. And those ovarian tissue fragments, they do not last forever. They lasted for about 2 to 7 years, right? So, I mean, but as long as they lasted, out of those 9 women who got ovarian tissue from their siblings, monozygotic twins, 7 of them got pregnant. So the success rate was very good, right? And then here is another study, which is very interesting as well. They looked, in Europe and Holland, there is a lot of ovarian tissue breeding has been going on for years and years. So they reviewed their literature over 20 years. They have about 500 patients who had frozen their ovarian tissue. The mean age was only 22. And most of those patients, 1/3 of them were younger than 18. Actually, 15% were prepubertal, right? Most of the indication was because of cancer, but some of them have benign gynecological problem that needed the ovary to be removed. And some of them have increased genetic risk for premature ovarian insufficiency, right? Out of those 500, about 21, only 21% patient underwent ovarian tissue transplantation back, which is about 4% of the cohort, right? And out of those 21 patients, 7 of them were able to conceive. So that's about 33%. So you remember I talked to you about embryos and I said every embryo will give you about 40 to 50% chance? Well, this is 33%, right? So I think that's not bad, to be honest. And those patients have more fragment that they can transplant as well. So I think the advantage of ovarian tissue is you freeze a lot of eggs in a small little piece of ovary. It's not like you're freezing 10 or 20 eggs, right? You're freezing a lot of eggs. But it's on us to do the research to make sure these procedures are done properly and those patients can be successful and can become pregnant. So what is the problem with ovarian tissue freezing and transplantation? The only problem is you can, in the wrong patient, you can actually transplant the cancer back, right? Because the cancer doesn't just stay where it is, right? Especially for blood cancer. If somebody had leukemias, most of the time the cancer kind of circulate all over the body, right? So if you take ovarian tissue from those patients, then that ovary may have some cancer cell. And if you put it back, then there is a risk of transplanting cancer back, right? And there are some animal studies that showed truly when you take ovarian tissue from leukemia patient, you put them in immunosuppressed mice, the mice can get the cancer. So it's very important to choose your patient very appropriately, right? So leukemias are not a good candidates for freezing tissue to transplant to the same patient, but it can be a candidate for freezing tissue as long as we can in vitro mature that tissue in the future. So there is a lot of research. I'm going to talk about research, but there's a lot of research now going on, try to in vitro mature that ovarian tissue from cancer patient so we can actually mature the follicle in small little bubbles. You can see that, mature the follicle and make eggs in the dish in the lab and not have to transplant that tissue, which may contain cancer back to the patient. So, I mean, there is a lot of promise. And there is people who are working on artificial human ovaries as well. So there is a lot of promise, but still a lot of research to go. So now comes the most important thing. This is wonderful what I'm saying, but it really takes a team, a huge team, especially when it comes to cancer patients and those. It just takes a team across the whole institution, believe it or not. So what can you do to help us out? I think, for you guys kind of talking to your patients, not only cancer patients, but even just regular women, like anybody in their 30. Do you have kids? Yes or no? If the answer is no, are you interested? And the answer could be yes or no. And if they're interested, I mean, somebody in their 30, I say that would be the right time for them to have their families, right? But if they are not able to, not want to, or for whatever reason, then maybe you can discuss with them fertility preservation. I mean, it's really a good option for younger girls. But those people who wanted to do it, then of course, for the medical assistant, There is a lot of things that, clinical support for our medical assistant do a lot for those patients. They draw blood from them. They do their priors. They coordinate their care. They help with monitoring. I mean, they're really wonderful. We have a couple of nurse MAs, and they're amazing. And we're always looking to hire more MAs if anybody's interested. What about the nurses? Without the nurses, we would not be having that wonderful UChicago program. The nurses are really our right hand. They're educators, they're navigators, they teach patients everything about the cycle, they coordinate care, they teach them the injections, they manage complex problem with us. And more important, they're really there for the patients. Patients want to talk to somebody. Like this thing is not easy. They want to bend, they want to learn, you want to make a mini REI of every single patient in no time. You want them to learn everything that we know, and we do, and we don't have time for that. So our nurses are really a wonderful resource to kind of guide us through this. So yeah, we have a wonderful program at UChicago, and we're happy to see patients, relative, friends, patients, whatever you want us to kind of see, we will be happy to see that. So in conclusion, fertility preservation is really the standard of care for many indications, medical indication and even social indications, right? And the ability to have children is just not it's not something trivial. Is a quality of life issue. And there is a lot of research that show that infertility is associated with a lot of morbidities, including social, economic, psychological morbidities and physical effect. And there is a lot of research indicating that there increased heart disease in patients who are trying to get pregnant and not able to do so. So I think I'm here to just say we are available. There is a lot of resources. You can call us. You can send us messages. You can epic us, whatever you want. You can secure chat us anytime, and we're happy to answer questions for you. Here's my email. Here's my cell phone, and I'm happy if anybody have any questions. I'm happy to take these questions as well.
Are there any questions out there?
Dr. Salih, that was an excellent talk. One of the things you briefly mentioned was I have two. You mentioned that the costs can be prohibitive. So, what are some of the ways that some of our nurses or medical assistants could help patients navigate, how they get things covered? And then the other aspect, you touched on kind of the ethical issue of what if somebody freezes an embryo or even freezes eggs and then they decide that they don't want to get pregnant, or maybe they got pregnant but they still have 3 embryos left? What do they do with them, and how do you counsel patients about that aspect of fertility preservation?
These are wonderful questions, Dr. Christmas. And, as far as finances, to be honest, is so complex. We are very lucky in Illinois that is a mandated state. So a lot of patients with infertility get covered, and anybody with cancer get covered, and anybody who's having issues for gender affirming surgery will get covered as well. But social fertility is not a universally covered situation, right? So that's the problem. We see a lot of we see a lot of, our own people as well. So some insurance do, some insurance don't. So I think it's very important that you look at your insurance plan upfront when you have that way to change it, and look around, because we have some very good insurance at UChicago, and some do and some don't. So it's very important that you look into this. Number one, we do have financial counselor, a couple of them, Nancy and Erin, and they're amazing. And they will go extra mile to help patients out. There are some grants out there. At University of Chicago, we have the Lion Grant. It's mainly for cancer patients and I've done a lot of patients on this Lion Grant. So it will cover egg freezing, it will cover ovarian tissue freezing, sperm freezing, as well as testicular tissue freezing for cancer patients. So that comes from the Comer Children's Hospital. So that's been an amazing resource. We also are members of the ARC, and ARC is a fertility-led society that will fund IVF cycle for patients. So they will give you loans out. And those loans have very minimum APR. And then basically they will give you like 10K, whatever it is, to do the cycle if you're really interested. But I would say look at your insurance very carefully and choose very wisely, because there are a lot of variation in the insurance that we have nowadays at University of Chicago and everywhere else, right? So that's be my advice. And give us a call. Like I say, my financial counselors are amazing. They know way more than I do. The other question about the eggs and embryos, and this is really important because this is why I like freezing eggs for younger women, because the eggs are your properties. There is no question asked. If you don't like them, you dump them, and that's fine. Nobody throws them away. Nobody's going to ask you. You keep them as long as you want. Embryos is a joint custody, is a property of the woman and the source of the sperm. Of course, if you use donor sperm, is yours. But then most of the time, if you use a partner or somebody you know, then unfortunately, I've seen this situation in my career where people are in very good situations and then have embryos, and then suddenly things doesn't go very well, and the woman cannot use those embryos. I've seen it, to be honest, and it's very painful. So I think it's very important for women to think out for their own, and it's good that fresh eggs and frozen eggs, both of them have good outcome. So think about yourself first before everything else. However, if you want to do embryos are helpful because they give you more milestones. We said not every egg make an embryo, right? And not every embryo make a baby, and not every baby is a live birth, right? So there's a lot of continuum, right? So if you make embryos and you have more information about those eggs, and if you make embryos today and you don't make a lot, then you can have more eggs and more eggs, right, while you're young. But if you wait until you're 50, whatever, and then you make embryos and they don't make embryos, you don't have a chance at that time. So there is pros and cons, right? But the truth of the matter, what do you do with the embryos if you have them? So what do you do with the eggs if you don't want to use them? This is really important because some people want to donate their eggs, but you cannot donate the eggs you make for yourself unless you specify this upfront and do FDA workup. There's certain FDA. So if you donate your egg to somebody, like you want to give them to somebody, you have to, they treat them like liver donation and kidney donation. So there is certain history, physical exam, or certain labs that have to be done in certain laboratory, FDA approved laboratory that we send out. So you have to specify this upfront. You can't just come up as a fact and say, oh, I want to give this X to X and Y. It's not going to work, right? If you cannot donate them, of course, you can use them or you can keep them frozen or you can discard them. Embryos are difficult because depending on the state and depending on the laws, I mean, these things are very flux. Generally speaking, we say embryos, you can donate them for research, you can donate them to other couples, and you can use them or you can keep them frozen. So it's a bit tricky with embryos, but you know, there's pros and cons for everything. I think that's again we have counselors, reproductive health counselors that we will advise women to talk to if they have any issues with this or any questions about freezing eggs and freezing sperm. But again, I would say I'm really strong advocate for fertility preservation because I've seen a lot of patients in their 40s, and I've very hard on us when people can really have their own genetic kits. And then I've seen people now in their 30s, and actually I've been around long enough that I see people freezing eggs and I see people using them, and I see people who are single and now they have partners, they want to use their eggs, and you know, it makes a very nice stories.
Well, thank you very much. If nobody else has any questions, I think we're done. Thank you for doing this.
Thank you, everybody. Thanks, Dr. Christmas. Again, any questions, please send us an email, message, phone call. We're available.
Thank you.
Thank you. Bye.
Thank you.